If you can't equalize, abort. A case presentation by Dr. Matthias Nacetto, performed by Dr. Franz Cranier. This case study involves sinus barotrauma and tips for its avoidance. The diver was a 26-year-old woman with approximately 200 lifetime dives. The dive itself was fairly simple, a single morning dive to a maximum of 26 meters. She reported no difficulties equalizing or any other complications during descent, but while approaching her safety stop near the end of the dive, she was struck by a massive sudden headache, nausea and vomiting. She aborted the safety stop and ascended directly to the surface. The headache and vomiting continued on the boat, and she experienced an onset of what she called dizziness. The crew helped her remove her gear and administered oxygen. After a few minutes with no improvement, the crew recalled the rest of the divers and called the emergency medical services as well as the DAN hotline. During the course of assisting the diver, further discussion revealed that the dizziness was reported as true vertigo. By vertigo, we mean the sensation or hallucination of spinning, often accompanied by nausea, vomiting, and jerky eye movements called nystagmus. It's accompanied by a loss of balance and is usually related to some irritation or damage to the inner ear. In a diving context such as this, vertigo is usually suggestive of either inner ear barotrauma or inner ear decompression sickness. Inner ear decompression sickness is quite rare, and the onset is usually not that sudden or dramatic. And so in this case, the possibility is rather that it either would be inner ear barotrauma or possibly alternobaric vertigo. Alternobaric vertigo, which is most common during ascent, occurs because of unequal stimulation of the vestibular system as a result of a reverse block leading to an accumulation of gas in one middle ear relative to the other. However, alternobaric vertigo is always short-lived, and so any vertigo lasting more than 10 minutes or associated with other symptoms should not be presumed to be the result of alternobaric vertigo. Distinguishing inner ear barotrauma from inner ear decompression sickness is not always simple. The type of dive and breathing mixture, level of exposure, and of course decompression profile all need to be considered. But even the experts sometimes have difficulty making the distinctions. As a result, we always recommend that someone with vertigo symptoms should be treated as if they have decompression sickness in terms of oxygen breathing and possible transfer for recompression, whereas the possible diagnosis of inner ear barotrauma means that they should refrain from equalizing attempts or straining and lifting heavy equipment. Headaches are a very common diving complaint, and they may be associated with sinus barotrauma. When they are, the sinuses involved usually determine the region of headache. The frontal sinuses would present above the eyebrows, the ethmoid sinuses between the eyes. The maxillary sinuses often involve the teeth, and the sphenoid sinus may refer to the top or the back of the head. But the headache related to sinus barotrauma usually remains fairly regional and tends to resolve upon surfacing. In this case, the headache appeared to get worse, particularly as ambient pressure continued to decrease, and it also was less well localized. This suggests a possible rare complication of sinus barotrauma called pneumocephalus, or basically gas leaking from the sinuses into the cranial cavity. The sudden onset of massive headache associated with nausea, vomiting, and vertigo was suggestive of this rare diagnosis. The diver did report some difficulties equalizing and some sinus pain during the descent, as well as a sensation of pressure later during the ascent to the surface. The diver also had a history of a cold, which increased the chances of severe sinus barotrauma. Pneumocephalus is usually only diagnosed with imaging. However, small amounts of gas may actually be reabsorbed by the time they actually get to the scans. There's a relatively small window period in which the positive diagnosis may be made. If pneumocephalus is severe, it can cause derangement of brain structures to the point where it may even be fatal. The underlying mechanism of this type of injury is associated with reverse block of the sinuses. In other words, the gas inside the sinus cavity continues to pressurize and ultimately ruptures the weakest part of the walls of the sinuses adjacent to the cranial cavity or related structures. The mechanism of injury is associated with a reverse block of the sinuses when mucus or inflammation narrows the passageways between the nose and the sinuses. Pneumocephalus may result in anything from headaches to a life-threatening neurological deficit similar to a head injury or a stroke, based on the amount of gas, its location, and the disturbance of the underlying tissues. Management remains largely the same, with head elevation as for inner ear barotrauma and oxygen breathing. Ultimately, upon admission to hospital, the diver will receive antibiotics and, in rare instances, may need reconstructive surgery. By the time this diver was able to get to a scan, there was no evidence of gas in the cranial cavity, and so the diagnosis could not be made conclusively. However, the presentation and association with sinus barotrauma made the diagnosis highly suggestive. During the 6-month follow-up, the diver had a very good outcome, no further complications, but did not resume diving. Concluding remarks. One of the first rules we teach student divers is to abort a dive if they experience difficulty equalising. It's probably one of the first rules we tend to break, especially if we've invested time and money to get to a particular dive site. The questions related to the use of decongestants that often come to the DAN hotline show us how this common concern affects diving. It's important to remember that the most important phases of a dive are the descent and ascent. But while descending is a matter of choice, ascending is an inevitable requirement. And so, if you are to choose to abort a dive, you should abort it during descent. When in doubt, don't. Bear in mind that cold and the duration of the dive may aggravate the situation. And so, while sometimes it may be possible to equalize the ears on the way down, the chances of developing a reverse block increase as a function of the duration of the dive. We'd like to encourage you to also listen to some of the other podcasts on equalising and equalising difficulties.